Ini adalah amanah. Melindungi pekerja merupakan panggilan yang mulia untuk kami.
Bukan hanya tentang hari ini, tetapi tentang perjuangan menjalankan roda kehidupan.
Karena kami ingin terus memberikan apa yang menjadi mimpi besar anak-anak kami.
Kerja keras untuk keluarga demi masa depan yang bebas cemas.
Terima kasih karena telah melindungi kami sebagai tulang punggung keluarga.
Amanah besar yang diberikan kepada BPJS Ketenagakerjaan mendorong kami terus berinovasi. Apapun resikonya,
Kecelakaan kerja di saat jauh dari keluarga,
kehilangan mata pencarian,
Hari tua yang tak berdaya.
Bahkan kehilangan nyawa sekalipun.
kami berdiri di sini untuk membawa arti bagi keluarga. Negara hadir melalui BPJS Ketenagakerjaan untuk mewujudkannya. Perlindungan pekerja sejahtera.
We will go to the agenda of keynote from our keynote speaker. I would like to invite our keynote speaker, Ms. Tanimizu RN BSCN MN. She is from WHO, representative for Southeast Asia. And today she will give us the topic about perspective of the WHO to health security, current condition, and prediction. And before our speaker give her topic, please let me read for her curriculum vitae. Okay, this is our speaker curriculum vitae. Ms. Tanimizu, based on in New Delhi, India. She is currently a technical officer for nursing and midwifery at WHO, and she has experience from previous role at WHO and University Health Network. Ms. Tanimizu already has a Master of Nursing in Health System Leadership and Administration at University of Toronto, and she has many skills in area of critical care, patient education, clinical research, clinical trials, oncology, and more. And she has a lot of contribute valuable insight to the industry. Okay, that's a short of curriculum vitae. And now, once more, I would like to invite our honorable speaker, Ms. Tanimizu. Please, all the time is yours for like 45 minutes. Please welcome Ms. Tanimizu.
Thank you very much for the kind introduction. I hope you can hear me. For some reason, my sound system is a little off today, so I'm not sure if you're able to hear me, but I think you are, so that's great.
Yes, I can hear you.
Nodding.
Thank
Yes,
you.
great, thank you. Well, thank you very much. So my name is Tanimizu. I am the Technical Officer for Nursing and Midwifery at WHO Regional Office for Southeast Asia. And this morning, I have the pleasure to be with you. Thank you very much to the conference organizers for the invitation. And I apologize, I was a little late as I had to take my son to the hospital. Yeah, and we're back now, but I just returned, and that's why I'm having some problems with the sound, and I didn't have time to adjust, but I hope it works out. And so today I'm here to talk to you. Let me just share my screen. Okay, so we're talking about global health security, and I think it's such an important topic to discuss as we are, we're just coming out of the pandemic, hopefully, and we are experiencing a lot of a lot of other health emergencies, as well as natural disasters, especially in our region in Southeast Asia. So I think this is a really, good opportunity to discuss these items. And so today I'd just like to talk to you about some of the things that I have in perspective and tying it into nursing. So WHO, as an organization, we are an independent specialized agency of the United Nations, which is established on the 7th of April, 1948. Our goal is to ensure the highest attainable level of health for all people. We actually have headquarters in Geneva, Switzerland, and we are divided into 6 regional offices, as we have country offices represented in more than 150 countries. So therefore, we split them up into the regions. One of them being the Southeast Asia region, which I am sitting in New Delhi, India. And we also have, Indonesia is one of our countries in Southeast Asia region, but our neighboring Western Pacific region is in Manila, and we work a lot alongside with them as well. And that's why I have the diagram here, just so that you know how we are split up and how we work. So all of us are working towards the Sustainable Development Goals. These are 17 goals that our leaders in the world have committed to. So by 2030, we're hoping that we can develop a community with an environment and basically a country where we are able to, we have sustainable future, right? And so as for working in health, SDG 3 is the core of what we do, which is good health and well-being. And what sits at the core of SDG 3 is actually universal health coverage. So universal health coverage, you may hear me say this a lot, or other, world leaders in global health. But this is really about making sure that everybody, anywhere in the world, regardless of where they are, can receive quality health services when in need without suffering financial hardship. And it includes this full spectrum of essential quality health service, from health promotion to prevention, treatment, rehabilitation, and palliative care. So why is this important to the topic that we're discussing today? Because without universal health coverage, we can't ensure global health security, right? Because we want to make sure that everybody has access to health when in need without suffering the financial hardship. So it shouldn't mean that because, a typhoon hit or because an earthquake hit, that people that are in need of health services cannot access. This is the core essence of universal health coverage. And as Dr. Tedros, our Director General, said, all roads lead to universal health coverage. And we cannot achieve SDG 3 without ensuring universal health coverage. Also want to link that, what we do in health, for example, for the SDGs, well, when we're strengthening health, we're not just strengthening or, achieving towards SDG 3. We're actually, when we talk about nursing, for example, when we strengthen nursing, we're actually hitting SDG 3, which is good health and well-being, SDG 4 on quality education, for example, gender equality as well, given that 89% of the nursing workforce are women, and also decent work and economic growth on SDG 8 as well, and other areas. And this is important because nursing does hit not just SDG 3, but really all these aspects of SDGs, not just the ones that I mentioned, but just giving that to you as an example. So in order to achieve universal health coverage, again, we need to have access to health services, quality of services to improve health, the care that does not cause financial hardship. And primary healthcare is at the cornerstone of this, because we need to be able to reach the furthest people, the ones that are living in the furthest islands or in the villages. And how do we measure this? We measure it by outcome and output. So it's we need to make sure that we have improved access to quality essential health services, and that countries are enabled to strengthen their health workforce. Again, this is important because if there is no health without health workforce, we cannot achieve universal health coverage without health workers, right? So where are we now with achieving universal health coverage, and how many health workers are there in the world? So this number has been changing over time, but we know that as of right now, there is a shortage of 10 million health workers needed to achieve and sustain UHC by 2030. So that's a huge number, right? 10 million health workers. And we know that more than 50% of the health workers are actually nurses. So we know that there is a global shortage of more than 5 million health workers in the world. When we talk about health workers for universal health coverage, we don't just look at the numbers. We need to make sure where they are employed, what type of education they've been receiving, are there what types of employment opportunities there are, and how much they're able to deliver quality health services, because this is what links them to universal health coverage. So just having this background. So our Southeast Asia region is comprised of 11 countries. So as you see, Indonesia is one of the countries in the Southeast Asia region. We are the smallest number of countries in one region, but yet we house a quarter of the world's population, right? So 1 in 4 people in the world actually live in the Southeast Asia region. So when we look at our region and the health workforce, specifically talking about nursing, because this is our area that we're discussing today. When we look at the density of nursing personnel, this is from the State of the World's Nursing Report. You can see most of the countries in our region are listed as orange or bright red, meaning we are actually lacking. We are experiencing a shortage of health workers, right? And if you think about it, so the State of the World's Nursing Report came out in 2020, and we know what the world was going through in 2020. So these numbers were actually showing that there was a shortage prior to COVID-19. And we also know that during COVID-19, there was a lot more demand of health services as well, and many health workers being reoriented to other health services. So we know that this number may not be as accurate, but this is what the numbers were in 2018. When we look at how many nurses there are by WHO region, we can see that in Southeast Asia, we have about 16.5 per 10,000 population, meaning if there is 10,000 population, there are 16.5 nurses available. Globally, the average is 36.9. So you can tell that the number is actually, we are experiencing a significant shortage compared to other countries such as Europe and the neighboring region of Western Pacific as well, of 36. What's the health workforce situation of the production? So how many health workers are actually graduating? Because this is a number that we need to look at in order to see the availability of nurses that we have in our region. So you can see, compared to OECD average of 43.6 graduates per 100,000 population, we have all the countries that have reported have less numbers of nurses graduating, and also medical doctors as well. Now, you can see the trend, and we have been having an increase. So we have improvement in the availability of doctors, nurses, and midwives available in the region. Currently, our regional average density is 28.05 per 10,000 population. Now, we're still short of the global the aim or the goal of 44.5 doctors, nurses, and midwives per 10,000 population, which is the number that we're aiming for towards what we came up in 2016 for 2030. But this number does represent an increase of 30.5% increase since the start of the health workforce decade, which we have launched in 2014 in the region. So we can see that all the countries are, we're really working hard towards meeting the target. And you can see, for example, Indonesia, you are almost there. And again, this was the data in 2019 and 2020. So, when we do the next round, we may see that, Indonesia has actually achieved that, the density goal. Now, I talk a lot about density and availability, but it doesn't mean that increase in availability is linked to increase in health service coverage. So this is important, right? Because, again, we want to meet the we don't want any shortage of health workers, but at the same time, we want to make sure that there is health service coverage available for the people that are in need of health services. So you can see that here, this is a graph showing the link between the relationship between health service coverage index and the density of health workers in several countries, basically showing that it's not linear, meaning it does not mean that if there is an increase in health workers, that there is an automatic increase in health service coverage, because we need to look at geographical distribution. We also have to look at task shifting, what and other areas of health workforce, agendas that relate to health service coverage index. So again, when we talk about geographical distribution, so we know that health workers tend to focus more on bigger cities, but in our region, there may be more people living in rural areas, right, than the bigger cities. So this is how this is also what's important. It's not just about the pure numbers that we're looking at, but how many are distributed across the country, and what is the production capacity, of nurses, which I've showed you previously. So again, that was the data for State of the World's Nursing Report, which was data from 2018. But since then, we know what has happened, especially in our region. We've experienced fires, we've experienced floods, numerous earthquakes. So all these types of natural disasters caused by climate change as well, and air pollution also being one of the key factors in our region. But there are other factors such as food security, or increase of burden in non-communicable diseases, right? So many more people living with chronic diseases than battling acute diseases previously. And then we're also experiencing AMR, which is antimicrobial resistance, meaning many people are taking antibiotics, they are being prescribed, but unfortunately, this habit is causing more and more stronger bacteria that are becoming harder and harder to combat with the available medications that we have right now. So health security is definitely at a risk, right? Currently. What is the emergency care situation? So we know that over 50% of the global mortality has been attributed to the emergency medical conditions. And emergency disease burden is around 4.4 times higher in low-income countries than high-income ones. So this is also alarming for us, because we want to make sure that health services are available and that health workers are available to be there when an emergency occurs. And we know that emergency disease burden is 4.4 times higher in low-income countries. So, our chief nurse officer, Dr. Amelia, which you saw in the first slide, if you recall, she has mentioned that emergency care is in a state of emergency. As the reality of war, climate change, and global pandemics become ever more real, the pressure is building. If we don't act now, the systems we all rely on will break, right? So this is really key, because, this is what we're dealing with right now, linking it back to our topic of what we're discussing. This is the reality that we're experiencing. We know that, we're experiencing climate change. We're in the middle of, a few wars in the world, and global pandemics. And, who is to say that we're not going to experience another pandemic in the future, right? So we need to just make sure that we do have emergency care accessible, and especially in low-income countries or low and middle-income countries, to make sure that the disease burden of emergencies are lower. Now let's look at COVID-19. So what happened during the pandemic, and what really caused the service disruption? So again, we can't achieve universal health coverage without having the services available. So this was a study that was done to distinguish, or to find out what caused disruptions in health services. So you can see where I put the arrow. A lot of it was actually due to health worker availability. So it may have been because the clinical staff deployed, the clinical staff were deployed to provide the COVID-19 relief, and they weren't available for other services. We had insufficient PPEs, personal protective equipment, which I'm sure all of us have experienced during that time. And there were insufficient staff to provide service. So these are the direct health worker causes, right? But if you see, at the top one, for example, decrease in outpatient volume owing to patients not presenting. Patients are not going to come if there are no health workers, right? I understand that patients did not want to come, but maybe there were cases when they had to go to the hospital, but they knew that there weren't any health workers available, and therefore they didn't show. So there are direct causes and there are indirect reasons as well that are linked to health workers for service disruptions. When we look at the countries of our region and what types of services they were lacking it, you can see how most of the countries have struggled. It was really only a few countries that were able to continue health services without any disruption. But we saw that majority of the countries had some at least partial disruption in the health services available. So again, looking at disruptions in our region. So the few slides back when I showed you the service disruptions, that was globally. This one is for our region. So we can see where I've underlined in red is really the direct causes from health workforce availability and lack of health workers, for example. So related clinical staff deployed to provide COVID-19 relief, closure of outpatient disease-specific consultation clinics, PPE was unavailable, and again, insufficient staff to provide services. So this, again, links back to health workforce availability or lack of availability in the region, causing disruption in services. Now, these are really important for us to know because, what happened in the previous pandemic or the current pandemic is going to reflect on what's about to happen if there is another one, or what if there's another, health emergency or a natural disaster that happens that affects the region. Most likely this is what's going to happen. And that's why these studies are important for us to see, well, what can we do to make sure that this doesn't happen again, or that we are able to prepare for the next pandemics. So approach for overcoming disruptions. So, what can we do to overcome these disruptions that we were experiencing in our country? So one of them being the telemedicine deployment to replace in-person consults. So we did see that in few of the countries in the region that they implemented telemedicine to make sure that health services were still available with the short staff, and plus to make sure that those patients and the community that didn't want to come into the hospitals or the clinics, that they're able to still access health services through telemedicine, because that was going to be safer for them. Task shifting and role delegation, right? So we saw that a huge number of health workers were shifted to COVID-19 relief, which meant that the other clinics, had less number. So task shifting, meaning with the small number of health workers available, how do we make sure that the services can still run? So, this is important for interprofessional collaboration and working in a multidisciplinary team, right? So, it's really about, are we able to task shift to make sure that services can still be available, and ensuring that everybody, all those that are in need of services can access them. And so again, there are other areas that we came up with. Some of the potential approaches for overcoming disruptions. So these were actually from the countries of what they said. The government had mentioned this to us. And I think these are important to note for, again, future pandemics that may happen as well. So for our region, we actually conducted a situational analysis to see what were nurses and midwives' roles during the COVID-19 response in the region. So this actually, we collaborated with Universitas Indonesia and University of Kyogo in Japan. And we looked at nurses and midwives' roles during COVID-19 through surveys, literature review of documents and policies, and we also conducted interviews and expert feedback. So why we wanted to do that? We wanted to see what were the nurses and midwives' contribution to the COVID-19 response, and what can we do better? again, to prepare for future pandemics or for any emergencies that may happen. So some of the findings that we had were that in our region, nurses and midwives were involved in patient education and community outreach, direct patient care delivery, including psychosocial support, vaccination, which includes and then including testing and screening of COVID-19, telehealth services, as you saw that, some countries have implemented telehealth services, and conducting risk assessment. There were nurses and midwives who were involved in resource management, meaning HR management, so health, HR management, equipment, medical supplies, definitely in infection control, contract tracing, and that nurses were involved in coordination and communication, including patient referrals. But if you see here, like the roles of the nurses and midwives were really strong. It came out strong in direct patient care delivery. But what we found out, we then thought, what are the areas that we're missing and that we can work better towards for future? So we did think that we were lacking in involvement in policy making, so that, nurses and midwives were not involved too much in policy making or policy decisions, especially during COVID-19, which is important because, again, we as nurses, we are the ones working with the community. We understand what the community wants, yet we were not involved in the policy making. We were there to advocate for patients as well as advocate for the safety of nurses as well. We were lacking in incentives and psychosocial support to nurses. So nurses were definitely providing a lot of psychosocial support to patients, but there weren't much support to our own profession. And where were the incentives for working in such areas? We were lacking in some training. Nurses have mentioned, again, through the surveys and the focus group discussions that we had, that we were short in some of the training areas, especially to the nurses, on infection prevention or on COVID-19 information as well. There was lack of resources such as PPE, which could have helped when providing care for patients. Workforce management as well. So again, were there quick decisions on task shifting or where the health workers were going to go? So these kind of workforce management was also lacking. And really, again, as a conclusion, just wanted to mention that there is no health without health workforce. So what do we do for the future? We need to build motivated and well-trained health workforce that can adapt to these changing needs. We know the world is changing. We know that there are emerging diseases out there. We know that more people are living with chronic diseases. So how do we build a health worker workforce that can adapt to all these needs to adapt to what is really currently going on? We need to ensure training and education. I think this links to the next presenter, perhaps, on what types of training and education is needed so that our health workers, especially the nurses, can adapt to the changing needs and provide that support and service delivery that the community needs. What types of policies can enable health workers to practice to their full scope? Right. So again, this links to task shifting that we talked about. Were there some policies that actually didn't support nurses? And again, this is why it's important to have nurses in the policy decision-making table so that they can advocate for our profession as well and really discuss, what are policies that are actually providing them with that enabling environment so that they can practice to their full scope. Do other health workers, such as our physician colleagues or other colleagues, other teams, if the multidisciplinary team, do they understand? And how can we work together with other professions to make sure that we are delivering quality health services? So again, there is no health without health workforce. We know, that we are experiencing shortage, and we know that there are changing needs. But we need to make sure that the team that we build, the health workers that are graduating from our systems, that are in the health labor market right now, are motivated and well trained so that they can deliver quality health service. So that was actually it for my presentation, and I'd like to entertain some questions if possible, if there is time, and I'm sure there is time, but over to you, Chair.
Yes, okay. Yes, Miss Ai Tanimizu, thank you for your topic today. Thank you for your expertise in this topic. And for all participants with this topic, we can know about the situation and we can know about the trend or maybe some issue about health, especially in Southeast Asia region. So thank you once again for Miss Ai Tanimizu. And at this time, for appreciation, we will give you a certificate. And the certificate will be given by Rector of Immanuel Institute of Health, Dr. Wintari Hariningsi. Please welcome Dr. Wintari Hariningsi. And this is the certificate.
Thank you very much.
Thank you. Thank you. Okay. And that's all for the session from our keynote speaker. And for Ms. Ai Tanimizu, once more, thank you for your time for us. Thank you for joining us. But if you have any other activity, please, you can leave this room.
Okay, thank you.
Okay.
The academic community of the Immanuel Health Institute would like to thank Ms. Ai Tanimizu for participating in the international conference. The material is good, useful for lecture, student, and the Indonesian people. God bless for you.
Okay. Thank you for Dr. Wintari and also Ms. Ai Tanimizu. That's a little word from our rector for you.
Pak, hati-hati yo.
Bagi para pekerja keras yang berlomba dengan matahari pagi,
Turung Kang.
Ya, badai dengan kategori 4 ini datang dengan angin.
Bojoku ngapa?
ada jaminan kecelakaan kerja. Buat yang banting tulang demi cita-cita yang tersayang. Ada jaminan hari tua.
Pilat nggak? Boleh, Dok. Pokoknya Ibu dukung.
Hati-hati, Pak.
Untuk yang memutar roda mengejar rezeki, nggak khawatir jalani hari. Ada jaminan kematian dan beasiswa 2 anak. BPJS Ketenagakerjaan agar mereka bisa kerja keras bebas cemas. Pasti aman, pasti cair, pasti tenang. Perlindungan pekerja sejahtera. BPJS Ketenagakerjaan.
Aku mahasiswa IKI dapat beasiswa BNI. Mau seperti aku, kuliah di IKI. Kalau kamu, bagaimana? Aku mahasiswa IKI dapat beasiswa KKP. Mau seperti aku, kuliah di IKI. Selain beasiswa BNI dan KKP, ada juga beasiswa lainnya loh. Untuk lebih jelasnya, mari bergabung di IKI. Kami tunggu ya. Kamu tahu nggak? Apa itu? Di IKI ada banyak UKM tahu? Oh iya, mau tahu? Mau dong, ikut tidak? Oke. Nah, ini UKM-UKM-nya.